So yeah, welcome. I think this is the last session of this afternoon and of the conference of this two-day show. We had, looking back, I think we had various discussions on what will be the prerequisites, the most important prerequisites for actually doing big data or thinking about big data and associated applications. I think what was always mentioned or several times mentioned over these last 2 days was, well, we need a good digital health platform or digital data platform. Otherwise, it's going to be very difficult, very costly, and very time-consuming actually to even do and try to do big data. And talking about this data platform, digital health data platform, that actually was very often referred to as having both genomics data, clinical data, as well as phenotype data, so really patient data, more qualitative kind of data. And database really should ideally unite those two. So this final session addresses that question, and I'm very happy to have representatives from 4 countries here, Austria, Switzerland, England, and Germany, who will show us what they did in terms of perhaps implementing such a basis, a digital basis, for then going down the big data way. So they show us where they are and how they did it, and perhaps also shed a little bit of light what their plans are in terms of then really plugging certain applications onto that data platform. I'd like to start with Günther Rauchegger from Austria. He is Managing Director of ELGA, that is the organization that takes care of implementing the National Health Record. Dr. Rauchegger, we had, I think, 2 or 3 times over the last 2 days, ELGA was mentioned in various presentations, so I'm happy to have finally somebody on stage who could give us much more detail on how it really looks like. Thank you.
Well, thank you for the invitation. Well, I was entering the room this afternoon, what I saw was on the screen, ELGA. So I was quite happy, so yeah. Anyway, ELGA in Austria, ELGA is the German abbreviation for Elektronische Gesundheitsakte, Electronic Health Record in Austria. And when I talk about that, it's quite simple. We have only 2 basic principles. The one is the method of communication, as we have already heard today. We have a kind of bidirectional communication, meaning everyone is talking with every other by whatever. We also heard about paper-based faxes and email communication, whatever. Every communication primarily based on a sender-receiver situation, meaning a receiver needs or is a little bit depending on the sender that he gets the information. I think that's nothing new, and it's a common situation across Europe. Well, this will change with ELGA, and since we're a little bit lacking of time, in a way that we have, and there's nothing surprising, a kind of electronic health record platform that offers you the possibility to get this information whenever, wherever needed, independent of time, independent of location. That, I think, is nothing really surprising and new for you. The second principle is also very simple, but very difficult or was very difficult to implement in the Austrian healthcare system, as we really replaced also the content of communication. Perhaps you can read this paper-based document. We changed our documents to a clear definition on a CDA definition, clinical document architecture, a technical document, meaning that every document that is maybe available within ELGA looks like this discharge letter. We have a clear definition for discharge letter, for lab results, for radiology reports, meaning that all documents within ELGA have a clear definition. Of course, it's not only a human readable document, it's of course a document that can be processed by a machine, as is a kind of XML structure in behind, which enables you to use this data for whatever. And this was quite more complex in Austria, as you have to replace your document sources in terms they have to produce this kind of documents. especially when you need, for example, some encoding like ICD-10 link encoding for lab results, whatever. This has to be implemented in the clinical hospital information system and so on, in the existing system. So that's ELGA. 2 basic principles, and therefore I could already finish my talk. That's it. Right now, and I've already mentioned it, we are dealing with, when we are talking about ELGA in general, we are talking about supporting a trans-organizational process. We are not talking about ELGA when it's within a hospital information system, because there is already an existing system, a very specialized system for exactly this purpose. When we talk about ELGA, we are always talking about a trans-organizational treatment process and how to optimize this process, what is really needed in this process. And therefore, we started at the very beginning with these documents, meaning the discharge summary, lab report, radiology report, and also the e-medication. E-medication also is a project name for e-prescription and e-dispensation. In that case, meaning for inpatient treatment, of course, what you need, or you have, for example, your GP needs at the end, is a discharge letter. He does, for example, not needs the 100 lab reports that will be created during a hospital stay that are not necessary. But on the other side, if you send your blood probe to a lab, you need, of course, the lab result at the end. That's right now up and running. Of course, we're talking about other documents like outpatient nursing report and whatever might be possible, ending up in some patient summary, what's already mentioned in the last session, which would be quite nice to have at the end, a kind of one-page or a summary of a status of a patient. That are the documents that are either available in ELGA or we are planning to do this within the next month and years. When we look a little bit at the technology, don't be afraid or don't worry about the complexity. We have on one side some kind of central components which are used to, on one side, to identify each and every person or a stakeholder in this electronic health record. On one side, the patient. Therefore, we use the master patient index. On the other side, the healthcare professional for this HCP index, which is also required, as we heard in some talks today. We need, in any case, a single digital identifier, which is realized with this master patient index, for example. And on the other side, we have a very flexible access control system, a role-based access control system, which ensures that every data exchange is based or is controlled either by the patient or by at least by a legal foundation by the ELGA Act, as it was enacted in the end of 2012. And on the other side, we have our systems that get connected to the upper part, meaning we don't replace any system, any healthcare system, any lab laboratory system or radiology system, but we just interconnect them via these interfaces to a what we call ELGA domain. From a technical point of view, it's a XDS affinity domain that allows finally to exchange documents either with the patient, meaning the patient can receive these documents, or to exchange these documents between healthcare professionals. Once again, it's not necessary within a hospital, it's necessary when it comes to an exchange across organization. Well, the system is up and running since end of December 15, 2015. Right now, we have, I think, end of October, we skipped the 10 million, the number of 10 million documents within this system. more or less, meaning we have right now 1.8 million discharge letters and half five at some 10%, and you know the numbers right now. Also, nearly half of the patients or citizens in Austria had already any kind of contact to the system, meaning there is at least one document available in ELGA. So the system finally is up and running. Once again, back to the architecture. This might be very complex. You can simplify it, meaning that we have on one side the systems that create these documents and retrieve these documents. And the upper part is only necessary for cross-linking these documents. Once again, ELGA is an infrastructure to establish this cross-organizational communication. This reflects also the interoperability framework as defined by the European Commission, as we are talking here in the same way as from a technical point of view, we have application and infrastructure. Back to our architecture, it's the same as we have the cross-linking, it's the infrastructure, and the system that creates documents are more or less the applications that use this infrastructure. In our case, the application is document exchange, nothing else, for discharge, lab results, and radiology report. Well, finally, we have a very complex system for exchanging documents. That might be not the end of the journey. So we are looking forward, and we want to develop this ELGA towards a, let's say, generic eHealth infrastructure, meaning that we know we have hundreds of eHealth applications, and we look at them. You might identify that they're all, many of them look like the same. We can cluster them, we can derive some eHealth infrastructure components that are finally necessary to realize these eHealth applications. And also, when we have a look at what are these eHealth applications, there are hundreds of them, and some of them are, for example, sorry for the German presentation, some additional documents, for example, pathology report, or some where is it? As we had already this discussion today, e-vaccination, for example, passport. These might also be more complex, like, for example, any kind of workflow support, for example, for tumor boards. Or it might be also some extension in the direction, for example, to support telemedicine, to get closer to the patient, for example. These are all components that or these applications that might be or should be realized using this common ELGA eHealth infrastructure. Once again, this is what we already have, an infrastructure, a generic infrastructure, and we use it right now only for ELGA in terms of re-exchanging documents, ELGA documents, but which can be or should be extended by these infrastructure components, whatever it is, to finally realize these ELGA applications. That's our final goal, to have one common national eHealth platform infrastructure, which allows us to interconnect not only the hospital information system, but which should serve as a basis for all other eHealth applications in Austria. One of them is, and it's also not surprising, of course, telemedicine. When we are talking about telemedicine in Austria, then we of course are also thinking about one single platform, one common infrastructure that might be used or should be used or must be used finally when it comes to the integration of patient devices, for example, where we don't want to replace, or we don't want to limit the innovation by private companies, but finally every application should be made available, or at least the data, using this infrastructure, using ELGA, that it finally comes from the device itself to ELGA. So that we have one common central infrastructure, once again, that should be used for every EHS application. Therefore, the Ministry of Health is currently developing a framework directive for telemonitoring with the goal to give a national regulation for telemonitoring devices in Austria, so that finally this application has also a legal, or the interconnection of this device has also a legal basis, a legal or an own legal regulation to interconnect them. Finally, and that's the most important, for the interoperability of these systems. Other projects are right now, ones I've already mentioned, the e-medication project, which covers the e-prescription up to the dispensation in the pharmacy, including the workflow from your GPs to the pharmacy, whereas also the patient itself has an insight, of course, in his own documents, in that case, to the list of all medications, for example. Another project we are talking about right now is the vaccination, which we hope to make a pilot implementation within the next year, so that we have also here our first experiences for the documentation of vaccinations. In any case, we follow a roadmap to interoperability, which means finally we need to have the proper standards. In our cases, this is what I already mentioned, HL7 CDA documents, up to IAG as a process interoperability framework, which allows us to include all these components on a process level. These are the main foundation from a technological point of view that we have here, or that the interoperability can be realized. When we look at ELGA itself, these are some screenshots, what a patient can see and can do. This is the start page where you can have a look on your documents, your e-medication. You get an overview of which healthcare professional has already access to my data inside in your transaction log and so on. You can opt out from the system. You get an overview about your documents that are registered in ELGA. You can of course retrieve these documents from ELGA. You can also, you have a full control about everything within ELGA. You mean you can, for example, lock the document, you can delete the document, and so on. And so the transaction log, for example. So, how this is related finally to big data? Well, we have on one side the hospital, the discharge letter right now. The discharge letter, lab report, radiology report. We have also from a GP the e-vaccination and e-medication, from the pharmacy e-dispensation, the dispensation itself. And well, in the next future, we might have also from the patient itself, the patient vital parameter, blood pressure, whatever. All these together are stored or should be stored finally within ELGA, or should be made available using this infrastructure component ELGA. It might be used finally for big data. The only thing that we are still missing, and which you have seen in the previous talk from when it comes to using this data, is that ELGA itself is a citizen-controlled data exchange infrastructure where we do not have any legal basis, any legal act to use this data for big data right now. So we are still limited on for let's say for legal reason to use this data or to use this available information for big data analysis. Well, thank you.
Thank you very much, Dr. Rauchecker. As we will have a final panel discussion, I should ask that you hold questions until the very end when all 4 of them will be on stage. Next is Adrian Schmid from eHealth Swiss. eHealth Swiss is the national coordination organization for implementing eHealth in Switzerland, and Adrian is heading that organization.
Thank you. Good afternoon. Do I have to do something, or are the slides coming? Okay, for you, Switzerland is a small country in the middle of Europe. For us, it's a complex structure of 26 regions who are responsible for healthcare. So whatever we do in healthcare is balanced between the national level, the regional level, and also private organizations, because not compared to northern countries in Europe, Switzerland is very much also driven by private activities. The government normally only defines what are the rules of the game. So if you have new projects like big data or electronic health record, this is a major question of how to organize it and what's the governance and what's the responsibility. So meaning we have a national level with a health minister who has limited influence. He's responsible for health insurance, which is a point where he can act, and also for health protection, for instance, communicable diseases. But really the music is playing in the regions. That's where healthcare is organized. So therefore, the current state, when we look at big data, is a bit, we do have several initiatives started from different angles, but no national strategy so far. So aiming at what big data could be, but not really aiming right at the center. Maybe the strategy is yet to come. And I will now show you the 5 projects I picked to show you what are the approaches. They're very different and they're very interesting, and maybe at the end they will grow together to a national initiative. The starting point was a paper that was published by Swiss academics 2 years ago, where it stated that the digitalization of health is creating new opportunities, but also risks. That big data has the potential to make medicine more precise, more precise science, and more individual. That's why in Switzerland the term of big data is always combined with the term of personalized medicine. So meaning that conditions can be diagnosed more quickly and in more detail, and doctors have the possibility to have more personalized treatment that is adjusted to the situation of a patient. That's the starting point. And what are the projects? I'm beginning with Baxan. Baxan is actually a national project, and it's data collected from all people living in Switzerland who are mandatorily in a health insurance system. So we have 8 million people in Switzerland, and if we also take the people coming across border to work in Switzerland, there's more than 8 million data of more than 8 million people. So a great potential to do big data on this information, but there is a legal basis who defines what it can be used for, and this is so far only limited to optimize the health insurance system, meaning it's to supervise what the insurance companies are doing, also to see if the services are efficient and for good quality, but this information is not meant to be used in medical research, for instance. And there's a little bit fight between the health insurance companies and the national government, how to interpret this article in the law, and maybe the parliament will have to adjust and broaden this use. The second project, that was a bit too fast. The second project I would like to show is MiData. Maybe you were here yesterday. There was Serge Pignon's professor in Switzerland at a education school. He might have presented some points of it. The idea is that when we take a medical app from an app store, we start to store information. Actually, we donate all the information to whoever does a business model, maybe in Europe, maybe in the States. We don't know who we give the data to. And the idea of Me Data is actually to have cooperatives, regional projects that do collect the data in our name as users and partners in this cooperative. So the 5 steps that are also shown in the graphic is to gather health relevant data in a secure place, then decide actively that I donate it to be used in research, to participate in the project and giving access to the whole data or parts of it, and in that way to contribute to development of new treatments. So it's the aim to keep control of what's happening with our own data. This is a private project that was initiated by a university. I think it's a very interesting approach. If this is going to be something that will be regulated in Switzerland, we don't know yet. The third project is actually the project similar to the ELGA in Switzerland, the electronic patient record, elektronisches Patientendossier it's called. In Switzerland, ELGA is about 3 or 4 years ahead of us, but in principle it's exactly the same thing. We have decentralized projects that are connected with the same standards and connected to one national system in the front end. So it's the exchange of information along the pathway of treatment of a patient. It's health professionals who put information in the health record, but also patient can store information in the electronic patient record. We start with structured information on medication, laboratory, and vaccination. Those are the 3 documents we are just about to structure them, and the rest will also be unstructured information in the sense of PDF documents or images or whatever. The timeline in Switzerland is that hospitals will have to be connected to the patient record until April 2020. So it's a short and steep road to there. And the planning may differ because we have maybe about 12 or 13 regional projects that will be connected, and it's the regions who do their individual planning, so we don't know. Maybe there's some coming next year, but they should have finished their work in the spring of 2020. Similar to ELGA, the national law does not foresee access to this data for research. This has 2 reasons. The first reason is in the political discussions, the politicians did not want to overload the project with more points that could be discussed. So we said we start with exchange in information, maybe using them for secondary use can be a second step. And there's also a point that all this information is available in the primary system. So the patient record is only exchanging information, but it's information that is available in hospitals, in medical cabinets, in pharmacies. So you can also get them there if you want to do research. Of course, if you have one infrastructure connecting that information, it's easier to get access. And this is also what many people dream of, but this will be in the future. It is possible for me as a patient over the portal where my information is inside to take all the information out and give it to Me Data or whoever wants to do research with this information. So this is the electronic patient record. Then I'm coming to a national research program, Big Data number 75. This is running from 2017 to 21. Is funded by the government with 25 million Swiss francs, which is about 20 million euros. And this does not cover only the health domain, but general different aspects, sectors of society, to figure out what will be or should be the role of the government in big data in general. The idea here is to develop the technologies that are able to deal with this big amount of information. Also to establish infrastructures that show that there can be made reasonable use of this information, and develop learning algorithms to analyze it. So this is very generic for different sectors of society. We do not know if this is going to have any influence on healthcare so far. They also will define security standards when dealing with big data in Switzerland. So I'm coming to the last project, which is very important to be coordinated with what we're doing with the electronic patient record. It's the Swiss Personalized Health Network. It's a national initiative designed to promote the development of personalized medicine in Switzerland. Is also funded by the government with 70 million Swiss francs, so about 60 million euro, also running 17 to 20. And here also it's to develop research infrastructure and establish National Data Coordination Center. This sounds a bit similar to what we do with the patient record. And actually we do have a big need to coordinate, because the idea here is to have the bigger hospitals in Switzerland who do their research on their own today on their information, the information they have in their systems. And the idea is to connect them semantically, technically, so that if a hospital wants to start a research program, they do not only have their own information as a source, but also the information of maybe 20 or 30 other hospitals in Switzerland. So there's a great need to coordinate this technically with what we do with the patient record, but also about terminologies, how information is coded. And here I can say that Switzerland is a member of SNOMED International since 2015. So whenever we're not sure how to code information, we are going to use SNOMED CT in the future. The goal here is to promote health and prevention and diagnose more closely to the needs of an individual person. So I come to the summary. We have just launched as the intermediate organization between national and regional government a new e-health strategy. It is still a draft that is in the public hearing right now. We do have the situation, as I've seen, we have several projects, but no decision on coordinated political steps. Also in this paper here, which is limited to 2020. So far, the national government figured that the patient record and the personalized health network initiatives and all the funding, the research projects that are running, they want first to finish them and analyze them and then take decisions later. So big data is not, and I put a yet part of this draft, because there's a public hearing that is still lasting until February 10th. And when I listen around a bit in Switzerland, there's many organizations saying, well, you have a nice paper, but you forgot big data. So it's possible that they will force us also to deal with it, so that maybe at the end we will have big data inside. I don't know yet so far. So thanks. If you're interested in what we are doing, the first website is the more technical part, and the second is addressing the population and the health professionals. And thanks for your attention.
Thanks very much, Adrian. Next is, that was very good, climbing over chairs. Next is Nino Mangiapane from the German Federal Ministry of Health. He's heading Department of e-health and telematics.
Thank you. So with regard to your presentations, we have a lot. We haven't recently met, but we have a lot in common. I summarize for myself. So what we have in common, we will see. We will see. What I would like to do is to begin the storyline, why we are doing this, what stage we are at the current moment, which plans we have in the future, and the Marshall title is Unlock the Treasury and Setting the Mind Frame, which means it's not, and that we have learned for the last 10 or 15 years, it's not a matter of technology, it's not a matter of law, it's a matter of bringing people together and share some, let's say, visions and coordinate these parties. So you see, we have in common starting points, which drives us in every country. As you see, we have heard a lot about the driving forces the last 2 days here. What we are trying to do is make potentials possible. As you see, first point, autonomous living, which means staying longer in your home, which is not only a human, but it's also a fiscal challenge for social systems. The classic is better coordination of healthcare. We've heard the last 2 days a lot about that. We heard also in the last presentation, make healthcare more precise, which means the promise of big data. If you collect, the treatment will be more precise and will benefit not only the treated persons, but also the health system. We will see how far we are at the moment with that promise and the better use of skilled workforce. Because we all know that, for example, also in rural areas in Germany, we can build our supporting systems on the amount of physicians in the next 20 years. We are currently building our systems now. So we have to use technology to bring supply to those areas which are at the current moment beginning to decline. So that is the vision. What's the reality here in Germany? Yeah. You see, outpatient care. We are divided in 2 sectors. I've learned you in the Swiss have 25 years. We have only a few less federal states, but we are divided in every federal state between outpatient care, inpatient care. We have no interoperability of the systems. We have no fixed standards. We have, to be honest, that's one point I would like to address here, and on other opportunities. We could not expect and be so naive to believe if we support or deliver technology, the professions would like to communicate with each other. Why should they? Why should they if there would not be the necessary incentives? So we have, at the current state, not enough incentives for communications. What we have is an incentive for care, for individual care, but not incentives to work together. We have about 130 different IT systems in use here in Germany, in the outpatient care, in inpatient care almost 10, 15, but as mentioned, not interoperable. Proprietary language systematics, you see, what we need, I see there has been something disappeared. So needed communication platform for sharing and exchanging means. We don't have a communication platform, and that was that what we tried to establish with the introduction of the eHealth card almost 14 years ago. I have had the pleasure to accompany this process from the beginning on, so I could have had some insight in the progress or not progress in this case. Those of you who are familiar with our German legislation have noticed that we didn't proceed very fast. So 2 years ago, we've set up, or 3 years ago, we have set up an eHealth law, which had some, as you see, bullets here, rapid introduction of beneficial application means by law, the parties who are ordered to build up the infrastructure were given a task, and if they fail the task, their budgets had been cut. So this was sufficient. This worked. We have some improvements in the structure of the gematik. That's the by the self-governed body-owned company who has the task to build up the infrastructure. We have given them the task. Interoperability was mentioned here or in the last sessions as well. The directory and what we have introduced, as you see, is a claim for a patient for a medical plan and promotion of telemedicine services. This also hasn't been a successful story. We have, I will come later to that point, almost 200 different telemedicine projects in Germany. So no one, except one stroke treatment. That's the only one of these 200 telemedicine applications which had to find the way to general reimbursement. So we had to ask ourselves what went wrong with that supporting schemes, what went wrong with the self-governed bodies, which had 3 years' time to work over the reimbursement scheme, and what we have done is nothing. And for nothing, we substituted 2 applications, teleradiology and televisit. These 2 applications we have given written in the law, and which will be funded. But it isn't or couldn't be the case for on the long run that that politics will make sure that applications will go into the reimbursement scheme. So we have to put that experience in mind, because what we see is, and the title of this session and this event is Big Data. While we are struggling with the eHealth structure, we have a great development in other areas, so-called Big Data. And what we see is we have, let's try that one. These fields of big data applications, several ones and that's not only an enumeration of fields, but also listing of actors. And I mention that because in every field you have to deal with resistance. You have to deal with different interests, and you could not believe to address or target all the fields at the same time with the expectations of success. So you have to concentrate yourself on 1 or 2 application fields. What we have, from my personal view, we have heard a lot about data-related challenges the last days. Yeah, you see the key issues here. I won't mention them all, but my message is, yes, there are data-related challenges, yes. If you don't solve them, there will not be big data, there will not be broadband communication, because there will be no bit across through the pipelines if the data-related challenges will be solved. But you could not expect that the data-related challenges are all you have to solve. What we have to do, and that's the lesson, come back to the 200 telemedicine projects. What we have experienced is, yes, nice to have technical solutions in a convenient or local field, but no primary goal, no proof of evidence what kind of improvement this application has met in terms of makes the treatment easier, makes it cheaper, spares hospitalization or whatsoever. From the experience today, you couldn't believe it. But my fear is that in big data, we are running in the same deadlock. If we don't plan the big data applications in mind that at the end that the proof of evidence of these applications is the basis for reimbursement schemes and for success of big data applications. And that's one point we are addressing in our innovation fund, which is funded by, for 2016 to 2019, each year with 300 million euro. And as you see, nursing models with e-health was a big issue. 6 of 29 selected projects came out of this field, and telemedical concepts also play a role in most other selected projects. But I would say, nice, good, great. But what we are talking here about is telemedicine in the, I would say, conventional way. Yeah? We are talking about video communication, perhaps a little bit added with patient records, and that's it. Yeah? If we are talking about real big data, we talk about using knowledge we have currently in the systems, in especially the systems of the universities. And the following 3 slides I've borrowed from my colleagues from the Federal Ministry of Education and Research, which had set up the Medical Information Funding Scheme, which we one or other would have heard about. It means if we say big data are the new oil, or the oil of the 21st century, right? But you have to know how to drill, where to drill, and how to transport it to the surface. So, and that's the task of the medical informatics funding system. We have currently, you will see it on the next slide, I think, in the beginning of 2018, we have as an aim the establishment of data integration centers. We have 5 funded consortia, which each will build a data integration center. So nobody believes that we have one integration center. Nobody will believe that we will have several hundred. We will see how they will proceed in this case. What is important for us for the next steps? We have heard a lot about precision medicine. And so what we are lacking here in Germany is the proof of evidence that the data could really and measurably contribute to better treatment. These are necessary steps. Here, no, four consortia. With, you see, 17 university hospitals. The challenge at the current time is they have to build up the data integration center. We have to make sure that their development in their patient records will be synchronized with the development of the gematik, which also has the task to define a patient record. So what we are facing the next time, or the next years, hopefully with government soon, which can support the necessary next steps, is we have to build bridges and manage relations between resource, our minister and the Minister of Research and Education have joined to an initiative which will be established to this legislation and will cover what I've tried to explain. We have to bring together those who are in university clinics with those who treat people in real life, in not university settings, and make exchange possible and bring not only technological the data to the patient, but to close the cycle, to bring data from treatment, from outpatient treatment in perspective into the loop of research. What we have to do for this is to involve the relevant stakeholders, the organizations. As you see, we as a federal ministry have to deal with health insurance companies, with physicians organizations and so on. That's a task, and the new task is to bring these together with the parties the Federal Ministry of Research is usual to deal with. The most important thing is, and that's the message I would like to give here, is not to think about technological possibilities, but to make as early as possible clear what is the benefit, the postulated benefit for the point of care. So otherwise we will run in a deadlock, and in 5 years we will all sit together and talk about why we didn't succeed. So we are not on an island. We have to bring some of the things we have reached here into the European debate, and with regard to rare diseases and the increase of knowledge that, as we have yesterday heard, that the matter, the cases to produce evident measure of outcome, while we know that we have several subtypes of some diseases, we could not expect to gain insights nationally alone. So we have to make sure that we share the data over the borders of our federal states, Germany, and Europe, and it's a challenging time. It's an interesting time at the moment, and I'm glad that we could meet for time and join together in the next meeting. We will see how we have proceeded in the last 2 years, whenever we met. For the time being here, I would say thank you for your attention, and so we will discuss later. Thank you.
Thanks very much, Mr. Nina Manjapani. You said we're not an island. Let's go to an island and learn how oil drilling is going on in the UK. Zoher Kapasi is with us this afternoon, and he is heading operations in an initiative called the Greater Manchester Connected Health Cities. Stage yours.
Thank you very much. Thank you for the introduction. I must say this is the last talk, so I will be succinct. So in this talk, really, what I want to do is give you a flavor of how we're igniting a revolution in healthcare across the north of England through the learning health system methodology. So I know we all know this, but I thought I'd just emphasize. Here's the clicker. I thought I'd just emphasize by saying that obviously the imperative for healthcare to deliver better care for more people with fewer resources is now, stronger than ever. And this is propelled by the fact that we have an aging population with naturally more chronic conditions, but we also have the unnatural risks of diabetes through obesity. And in England, the demands on the healthcare setting are particularly more evident as well, driving this social inequality with variable health outcomes. So, to address this issue, the UK government has invested heavily in data-driven, evidence-based healthcare delivery. So, this is through several programs and methodologies, all with the primary aim to streamline and standardize health and care by exploiting the treasure trove of cradle-to-grave electronic health records. This has started to yield early dividends in the form of standardized information governance frameworks, standardized data standards. We also have the adoption of new technologies to derive actionable information from this rich data source. And one such system is the learning health system, which aims to basically utilize the rich source of electronic health records and derive actionable information. So essentially, this method is built on the continuous improvement. It brings together 3 ingredients. So one is data, as we've heard from all the talks before, but this data is in the form of electronic health records. 2, it brings together models and methods to transform the data into intelligence. And 3, it brings expertise to make sense of the models, all with the intention or with the objective to implement actionable insights back into the healthcare setting. The key metric for capturing value from the learning health system is data action latency. That is the time taken from when data is available to when an action is taken or the insight is implemented back into the healthcare setting. And in the north of England, there is great, I would say, energy and excitement from several organizations that are coming together to enable this continuous cycle of improvement. So there are indeed certain preconditions for the success of a learning health system. So one, the data must be fit for purpose. We need to analyze the data using the appropriate tools and methodologies. But more importantly, I think there's a need for a social license that permits the trusted reuse of the data. And this is associated with significant challenges, as we've heard, but I'll just point 3 challenges. So the first one, in many healthcare systems, there is a prerequisite that the data shall be used only for the purposes for which they were collected. And this stems from the fact that the capture of electronic health records is highly transactional. And in most cases, the experimental methodology is not factored in the recording process. And with the vast number of operating systems that are currently in place, there is considerable variation in the way practitioners record the information or use electronic health records themselves. Challenge 2 is the anxiety really associated with the need to make the data available to data scientists for research purposes. And this anxiety perhaps is not misplaced, at least in the UK, largely due to the failure of previous attempts to share patient information without building citizen trust first. And this is shown here by the care.data debacle. And this is not only specific to the UK, as an EU-wide survey has shown that, respondents are averse to sharing their health data, especially if the public benefit is not well defined or articulated. I mean, this is well known. Challenge 3, perhaps, is the competition between technology and traditional medicine. So there is indeed a lot of literature around the selection of the appropriate variables, model uncertainty, overfitting, and even selection bias, which can compromise the reliability of the results. So what I would like to do in the next few slides, really, is just to give you an overview of how we are overcoming some of these challenges in the north of England by driving public sector reform, by making better use of data to produce actionable information. So the Connected Health Cities program is designed to do just that. Across a population of 15 million, underpinned by a large program that aims to build trust with the population that we serve. So it is across 4 city regions in the north of England, underpinned by a £20 million investment from the Department of Health. And each participating region is currently in the process of building a learning health system and a connected health city. So this is a civic partnership between the local government, NHS, academia, and industry to really redesign at least 2 clinical care pathways. And to facilitate this redesign, each region has an ARC, essentially, which allows the reuse of patient data under strict information governance controls, but also trusted frameworks. So essentially, the ARC is an infrastructure space that drives both economies of scale and economies of scope through the optimal use of resources, where we bring together expertise, together with data, methods to create actionable information that can lead to change. So we're producing a shift from a fragmented ecosystem into one where new policies and new insights are derived on a continuous basis to improve healthcare. And underpinning the whole program, I think, is a diameter of civic trust, which is critical to the success not only of the learning health system, but also of the Connected Health Cities program. So what we're doing, for example, we have several initiatives on the go, but one such example is the citizens' juries, where we're deriving the real perception from the citizens on the use and reuse of health data. And this is accompanied by an interface that allows dynamic consent, where patients are informed about how their data is being used, and all basically under an information governance framework that enables the sharing and the trustworthy use of patient data. And this data has contributed to several care pathway redesign projects across the north of England. So for example, we have alcohol misuse in the northwest coast, We're looking at dementia and frailty in Northeast and North Cumbria. We're looking at healthier child growth in Yorkshire, for example, through the Bonnie and Bradford study. And we're looking at the better management of stroke in Manchester. So, for example, in the stroke pathway, we've seen, or we have contributed to a 28% relative reduction in case mortality for patients who have suffered an intracerebral hemorrhage type of stroke. So I think it is important to note that in all the regions, so this is a 15 million population, all the regions are using the same blueprint. So in terms of data governance, data access, civic trust, the application of new methods and technologies. I'd just like to give you, in the next slide, a flavor of more detail really on a care pathway that we're actually building in Greater Manchester. And this is just as a refresher for some of you who saw this yesterday, as my colleague Vicky presented this. So, for example, this is a care pathway investigating how antibiotics are prescribed in primary care with the objective of informing general practitioners on their prescribing behaviors, but also informing practices where overprescribing is occurring. So we are currently examining a data set of more than 5 million patients over a time period of 15 years, collected over a time period of 15 years. And what we're finding is there is this spatial distribution of low and high practices, prescribing practices across England. So this is represented by the red clusters and the blue clusters. So the blue clusters showing low practices, low prescribing practices. And this conforms with the map that I showed on my first slide, where you see this health disparity, this north-south divide in England. But we're also finding that there is considerable variation in the prescribing habits of practitioners, and 80% of this variation can be explained by practice characteristics and the characteristics of antibiotic users, rather than, and 20% really can be explained by the underlying incidence of disease. And all these are really key metrics that are enabling practitioners to refine their prescribing habits. So I said I'll be succinct. So in the interest of time, I'll finish here. But I will say that the National Health Service in the UK is awash with data, but starved of useful information from this data. And programs like the Connected Health Cities are basically exploiting healthcare opportunities by designing new models of care that are leading to the characterization and improvement of whole health systems. So thank you, and I'm happy to take any questions.
Can I ask all four gentlemen to enter the stage? We have a couple of minutes left for a Q&A and a panel discussion. Let me perhaps start with one question or comment. We've been discussing a lot about big data over the last 2 days, forwards and backwards, and there are a lot of people not only mentioning that opinion over the last days, but running around everywhere saying that big data, this is opening up a new golden era in healthcare. Now, what I heard from most of you is that we are still quite a bit away from it. So I ask you perhaps short statement from all of you. Is this oversold? Is big data oversold? Will it ever be able to keep its promises? Or is this just kind of a normal way to evolve towards eventually entering that new golden era? Adrian, if you want to start.
Well, when I answer this question, I reflect what we had the discussion about electronic health records 10 years ago. And then it was said, this is not necessary, this will grow by itself, and you don't have to do anything. Now, most countries are in this building these structures. There's globally no proof that this is cost effective. It's difficult to prove even that there's other benefits besides integrating the population, being part of their healthcare. And for me, this big data discussion is a bit similar. It came later, but it started as a big potential. But there's not in Switzerland, an established common sense. This is the future that we really have to go into, and where politics have to be active. That's why all these research programs are still running. And for me, I hope that at the end, in 2 or 3 years, the fog will clear up a little bit, and see, are there private initiatives that are interesting for the private companies, for themselves, or is it up to the public to do something about it?
I don't know if it's oversold, and I usually answer, I'm not a jurisdiction, but I have to answer as one. It depends. It depends on the field of application. I believe in the promising targets. I believe that even if we have a set of data records, that would not be the last step. So the next logical step would be what information get we collected out of these records. How so-called artificial intelligence, that might be at the moment a little bit overestimated. Yeah? But the next logical step would be what kind of information also for the physicians at the point of care. If we have 5, in my case, if I would have a chronic disease, visit 5 different physicians. So, and here is the PDF from A, there's the report from B. So what's the message? What's the message for the physician? So we have to develop the next logical step. And with that in mind, I'm very confident that we could proceed. Not that we save the world with big data application, but we would succeed, I believe it.
Well, I completely agree. When we get a new tool set, I think we can build higher houses and a new skyscraper, whatever. In Austria, and that's the matter of fact, we're just dealing with the basics. We are just dealing about how to combine these different data that's all spread across the country to, in a first step, to have at least a kind of what I've presented as a patient summary, a quick overview about the patient. We're not dealing about big data and what can we do on the top level. We are just working on let's say, on the basis in terms of electronic health record, and how can we use these tools we have right now to improve the treatment of a patient. I'm sure that with time, the time might come that this big data analysis is helpful as the amount of data increases day by day, and we need, of course, a new tool set to get out this information, as we of course need to extract the relevant information out of this. But right now, I think we are just working on the basis. I've heard from also from the other countries. First, we use the hammer, and perhaps in some years we need the laser pointer for pointing at the crucial information.
So in my opinion, I think the utility for big data persists. So I have 3 points. So first is, if you think about other sectors, so for example in the financial sector, the efficiency is driven by the use of big data, you're already seeing a return on investment. And that same sort of efficiencies, people, at least in the UK, are beginning to kind of understand that these same efficiencies can be seen in the healthcare setting. The second thing I would like to suggest is co-production. And this is bringing the patient, at the moment, is at the center of healthcare delivery, but bringing the patient with the physician in the same room to basically allow that patient to basically drive their clinical care. And this has to work, because my second slide, I talked about how healthcare systems are overstressed. But if you think about, we can't just keep on pumping resources because they're not there. They're finite, if you like. So basically, the only way we can kind of offset this is through the use of big data, through the use of patient data to drive patient care with co-production with patients. And the third point, really, I would like to say is, at least in the UK, and maybe this Connected Health Cities program is an example of there is significant investment in this space, which basically signals, the drive, or signals some utility for big data.
Thank you. I don't want to monopolize on the discussion, by the way. If any one of you in the audience has a question, please go ahead. Not at the moment.
This on? Oh, okay. So I think absolutely. So connectedness is a theme that is basically we are leveraging, across Manchester and across the north of England. And I think when you refer to that initiative, there is synergy and similarities that we are exploiting as well. So, for example, a lot of the activity is looking at driving or tapping into Horizon 2020 funds. And basically, we looking at understanding, basically the quick wins from the ECH program as well. Yeah, I'm not that familiar with our program, but what I can understand is that basically the connectedness and the bringing healthcare together is basically the central theme.
Maybe just, could you explain what these ARK stands for?
Oh, okay. So the ARK. The ARK is basically the covenant. Yeah. So basically a covenant that is going to save us from the data flood, essentially, but also a trusted environment that brings together statisticians, informaticians, people with expertise who understand the data, people who understand the information governance, people who are healthcare change champions, so the clinicians who can drive this actionable information into practice, basically under one architecture, under one space, basically all working together, on this, on data that comes from patients. So that's basically the concept of the ARK, based on the biblical theme.
Thank you. I was wondering, we had a keynote yesterday, also from a gentleman from the UK, and he was mentioning that he sees, some prerequisites in order for big data initiatives on a global, or not a global, but on a national level to succeed. He said, well, governments should support those with funding, but then again, that funded organization should be independent and should be allowed, and even should need to sort of found corporations, including industry, including other stakeholders, and of course, including the patients. So you have kind of a private-public company which is backed by the government, which is funded by the government, but apart from that, has complete different freedom and is even asked to work with the different stakeholders. Would that be a way forward, perhaps, to accelerate things? For example, Mr. Manjapane, I think we are, as you mentioned, we are having difficulties in Germany sometimes to move things quickly forward. Would that be an opportunity for Germany to think about such an organization to get, for example, Gematik a little bit out of the stalemate it is at the moment?
To give a political correct answer, I have to link it to the political responsibles. But if I would be asked to give an advice, I would say what we have seen is we would like this, we would like to make data pools, we would like to make investments in clinical IT systems, we would like to establish data stewards on stations, and so on and so on. My simple question was, could anybody of those who listed these things give an answer to the questions that political responsibles will ask? What do we get for that public money? What is your promise? What do we get for that public money? Show me, please. So, and that's a point I would like, that we have to sharpen the discussions. So that's crucial point. Henne I here in Germany don't know the English expression, but we have to, if we could not answer this at the great scale, we have to try to make the proof on a not as big scale. That would be my advice.
I can be provocative now and say, you know, we don't need even look into very big data, but taking the example of Germany, if we had a closed-loop medication operation in place in our hospitals, we could save 15,000, 20,000 lives a year. Isn't that enough evidence?
Yeah, that's right. Question is, should that be supported with official money, or it's economic evidence for itself? If the UKE in Hamburg established closed loop, they had their reasons why they did that. And the question is, why do not other university clinics follow the UKE? So there must be something in the process which is in the UKE in Hamburg different or not. I don't know it. And from my point of view, yes, there could be places or applications where it would be useful to think about such things. But in closed loop, I don't know. The question is always the simple one: what does it cost? What does it bring? So, and on what level do you ask for this?
Comments?
I think we should never forget who this data belongs to. It's your data, our data, your data. So the question is, who do we give our data to look after? Who's hosting it? That's the first question. Is it a secure place? Is it okay what they're doing? I think the second question is, who wants to use them for what? If the public money is in these projects, it should help, it should support public health in less people dying from medication errors. But there's also private companies, maybe that want to develop business models based on these. We see in Switzerland many the pharma industry is interested to develop new medication on the basis of research on a big amount of data. So we have to really, as you said, be more specific who owns it and who uses it. And I heard in the session before the idea of Finland having an organization who's responsible, and then a licensing system that we can apply. The government in Finland is the government who gives a license for organizations to use this data. I think this is an interesting model.
Yeah, interesting model, indeed. By the way, any questions in the meantime? Another question from the audience? Then I would like to get a little bit away from that discussion into sort of acceptance discussion a little bit, because I'm increasingly, or I'm always faced with these discussions when it comes to doctors or to patients, you know, showing resistance, mistrust, or similar things with regards to digital health or data, or digital data. Perhaps Dr. Racher, you can shed some light onto how that was going in Austria. I mean, I don't assume it wasn't a bump-free way when it comes to, you know, doctors' resistance. So that's part one. And second one, do you have any any feedback from patients or any data from patients, you know, who've been working or been dealing with ELGA? How do they see it after, I don't know, 2 years of operation?
Well, the first concern the professionals, doctors in whatever. We started with the hospital, and therefore they use already a hospital information system. And the basic goal was to implement, to integrate ELGA in a hospital information system in that way that it's not visible to the physician itself. So as we are talking about an infrastructure, about our communication infrastructure, we completely cover, or it should be covered by the system doctors already are using. The meaning a lab system or radiology system stays the same. The documents or the information will be extracted from these informations. A document will be created. This document is exchanged through this network. This is the ideal implementation. The real-world implementation is, of course, that they are dealing with these documents. They need to write these documents. They need to change their habits in terms that they need this structured format, have the different sections. They need an encoding for example, the diagnosis, ICD-10, whatever. This manual work. The less they have to do manually, the better the higher the acceptance, of course. So that means the real challenge is make the system in a way that it doesn't change, that the physician doesn't need to change his working style. That's the most important thing. In other cases, you have resistance. That's the way. A very good example is the implementation, for example, of the e-medication, as every GP's office or system has already a module for the e-medication itself. He needs to write the prescription. Of course, he prints the prescription, and the one side he prints the prescription on his local printer, and the other one goes to ELGA. So it's completely transparent. It doesn't see anywhere. That's the most important, to get acceptance. If not, you know, every second he needs time for whatever, for writing a document will be addressed and said, well, system, it takes time and can't spend my time to the patient. From the citizen view, there are some real nice examples that the exchange of this information led to a better treatment. In that case, that for example, in case of an accident, they had already some information about the previous treatment, and they had a real big benefit from already existing information. Since the GPs, the general practitioners, are not really connected to the system, as we're just rolling out the medication. We are not well experienced about these cases. For those patients, they're really actively using ELGA. That means they have the first time access to their own medical data. The acceptance, of course, very, very high. As to the first time they can see their own data, they can check who has access and who read the documents, who registered the documents. It's a completely transparent system. He can do electronically everything he can do also on paper. I mean, he can delete it, you can try to put it in a trash, whatever, you can hide it and so on. So this is very valuable for the acceptance of such a system. Yeah.
Thank you. Anyone want to comment? Anyone want to comment on that? Then yes, Stefan.
I thought, okay, I would have lost the opportunity for this question, but you came back to the patients. Actually, you have presented this initiative or project, whatsoever, cooperative MeData, and it's very interesting, of course, in itself, but it's also interesting because it matches this proposal in the Digital Health Society Declaration, or the work on it that has been launched in the preparation of the conference in Estonia, where they have, there's this concept of a data donorship also in this declaration, but what I wanted to refer to is this task force 2, I think, which is dealing indeed with this concept of how data could be shared for secondary data use. It's a working group led by Angela Brandt from professor at University Maastricht. And they made this proposal, and honestly, I've heard of this for the first time, and now I see the first example. They made a proposal to set up, I think, even a European cooperative or a network of cooperatives exactly for managing this task. So my question is, are there already any lessons learned for this cooperative? Is this it has a constitution and everything, but it is working already?
You can pass the microphone to two rows behind, because Serge Bignos is one of the promoters of this project, and he knows much better than I what's going on there.
Yes, we have first experience on use cases, and the cooperative have set up projects, pilot with the university hospital to allow a dedicated group of patients to document about their outcome, to allow from the start to provide evidence. It's not big data, it's small data, but to show the whole process from A to Z by having patients using mobile application, giving their consent to provide data for research in the domain of oncology, recovery after chemotherapy, and multiple sclerosis to measure the evolution of the disease. The first lessons learned is that the adoption rate of patient giving consent for specific studies concerning the disease they are suffering from is very high. We expected that, but we have the data. Second lesson learned is it is difficult to keep interaction with those patients over several months. So you have to add value. It's not enough to publish the results of the study 6 or 9 months later. You have to give direct feedback, and we have heard that over the last 2 days, how important it is to also give personal feedback to the person. So we are working on it. And the third lesson we are learning, and the panel is also representative, is the problematic is not a Swiss one. It's universal. And now we are working with the Berlin Institute of Health and also the University of Leiden to replicate the model, to replicate the governance, not for-profit initiative, to replicate the use cases, and to replicate by deploying the mobile application on the app stores and to allow different people to connect to regional initiatives.
Thank you. We're almost running out of time, so perhaps final words from you guys. Crystal ball question, perhaps a little bit. How would you judge? Is there any idea on the timeline when you will see first big data applications emerge from your platforms you have, from those initiatives you're actually running and heading? Any idea how long that might take? And perhaps a comment on, do you see the danger that kind of at the side of what you're doing with your national platforms, there are, I don't know, any public-private partnerships emerging that would just take an initiative and drive, you know, big data initiative as a side of what you're doing? So you know, let's start this side to be fair.
So just to start with your second point, I think to be nimble and agile, we need, you know, vehicles like public-private partnerships to be able to accelerate the exploitation of big data. That's my opinion. But if you're looking at the future, so I think, you know, we're seeing the fruits of kind of the big data kind of phenomenon, if you like, very early on. So I mentioned the stroke pathway. We're contributing a 28% relative reduction in case mortality from patients who've suffered from an intracerebral hemorrhage type of stroke. That's one life a month, basically. Essentially, that's what it equates to. So the answer to your question is yes, it's happening. it's only going to happen faster, better, more economical, I guess. There'll be financial incentives coupled with those kind of metrics. So that's my opinion. Thanks.
Thank you.
Well, when it comes to the big data, we have to divide on one side the academic view on that and what can be done from the academics, and the other side is what we do on a national level. When we talk about the national, it's my part, the national level, we have a clear, when it comes to the time, the question of the time and when can we provide what and what might be possible. We have a clear roadmap, meaning that we are trying to develop this ELGA infrastructure to, let's say, a generic e-health infrastructure till the year 2019, 2020, offering possibilities depending, of course, we need a legal regulation. That's also an obstacle we are facing. We need legal regulation in terms of how can we use this data that might be provided by a network like ELGA, and that's the big challenge. It's not, as you mentioned, it's not a technical point of view as we can offer any possibilities, and it might be also possible to use this infrastructure for big data analysis in the near future. It strongly depends who is feeding the system and who is extracting the system and who is doing what. And there are some unanswered questions like pseudonymization, anonymization, and therefore without a clear framework, a legal framework, it's quite hard to decide when which application might pop up and which technological analysis and frameworks are running. We have, of course, some projects running also from an academic view to answer the very specific question, but in a generic approach, they are missing some, or most of the framework is missing, of course.
Yeah, 2 dates. Rollout telematic infrastructure will start next month. So if we say we will be through 2019, let's say, or 2018, let's say, this corresponds to a project I didn't mention before. We will launch at the beginning of 2018 for health cancer, lung cancer, with also first time ever in German history with co-financing Federal Ministry of Health and Federal Ministry of Research. The NCT, Professor von Kalle is not there, with industrial partners SAP and Siemens, and in which, for this case, we will make the proof. What does the results will be, which could be reached within the time frame of 18 months, starting from beginning next year. So we will be in end of 2019 in a position to talk how far did we get with a promise. If we use genome data, picture, image data, registry data for lung cancer, what kind, and that's my point, of care, what could we contribute for point of care 2019 for that indication? But to be honest, that's the only one I see at the moment. Yeah.
I think apart from this MeetData project in Switzerland, this is a Swiss personalized health network project where they try to connect the research organizations within the hospitals. If this is going to be more than just buying infrastructure, that they also be able to prove that there is really data coming from one hospital that can be used in many others. If this can be proved, I think this is an interesting project that will be finished in 2021.
All right. Thank you very much, gentlemen. Thank you very much for your presentations, for your discussion here. That concludes that session this afternoon. It also concludes HIMSS Impact Big Data Medicine this year. I'm looking forward. We plan to come back next year with an event around topic of big data. So I'm very much looking forward to that. Hope you enjoyed the last 2 days with us, and take care. See you soon, hopefully. Bye-bye.